Welcome back. We're still reflecting on the death of Charles Amissah on February the 7th. Paramedics from the ambulance service did their best to save him. 3 hospitals refused essentially to take him. This issue of we will not take a patient because of no bed is not new to you.
Yes.
In your work, I don't know, how do you deal with that? So do you just keep going to hospitals until they accept you? How do you manage to get a patient into a hospital when they keep saying no bed?
Unfortunately, that's the bitter truth. The bitter truth is we keep experiencing such situations whereby you get to a facility, you think should be able to accept a case, and they tell you that there is no bed. And what we do, sometimes the reluctance of releasing the bed, because once you release your patient with the bed, it means that you have decommissioned the ambulance. The ambulance cannot go back to the community itself to attend to another emergency. So most of the times that would be something that we normally don't want to do, because once you do that, the ambulance becomes decommissioned. So the last option for us to do is to release the bed to you and tell you that we are ready to release the bed. And with this kind of negotiation, we have seen situations whereby after releasing your bed, people who travel from one part of one region to another, transferring a patient there, will have to be there for hours
to wait for the patient to move
to a regular hospital bed before their ambulance stretcher is given back to them for them to return back to the wherever they came from. And they go through a lot of hardship and a lot of situations which are very
it's not ideal for the ambulance to offer its bed, but in the case that we referenced, the team offered that the hospital should even treat the patient within the ambulance.
Yes, because they saw the gravity of the condition of the patient and they realized that they needed the patient to be seen. Because if you, as Doc rightly mentioned, if you have a patient with polytrauma bleeding from different sources, the ambulance can do initial stabilization, but there is a limit to which the ambulance can provide care. When it gets to a point, you have something called the golden hour, from the time of injury to the time the patient arrives at the facility on a surgical table. So you want to look at that timeline and make sure that this patient who has a polytrauma is able to get to definitive care as soon as you can after the initial stabilization procedures. But if that happens, that's why they were ready to offer their ambulance stretcher, which we are not very comfortable doing because you decommission the ambulance. But because they realized the gravity of the condition of this patient, they realized that there was a need for this patient to immediately receive some definitive treatment to be able to survive.
Based on the guidelines you referred to, the 2012 guidelines, ideally what should have happened when the patient was sent to any of the hospitals, having had your team stabilize the patient and administered the first level of care? Based on those guidelines, what ought to have happened?
So yes, ideally once they stabilize, initial stabilization, and transported the patient to the facility, the patient should have been initially triaged. Okay, they should have tried the patient to see where the patient was at as far as stability is concerned and see whether they can initiate some initial stabilization procedures to maintain the patient at a very good spot before they can decide to refer the patient to another facility. So there was a need for that initial stabilization procedures. It might include things like, for instance, if there is a deep laceration or there is a cut on any major vessel, they can just go ahead and be able to suture those vessels, and that will prevent any further blood loss. They can even go into considering even blood transfusion on this patient. That will also help to stabilize the patient, and from that point, they could have decided to let the patient be sent to another facility. And with this being said, it means that the initial procedures to maintain the patient's life has already been ensured. So for such a patient, the ambulance crew could have transported to another facility.
So when they say triaging should be done, that triaging is without prejudice to whether there's a bed or not, correct?
Yes, so because the ambulance stretcher is available, you can do examination on the ambulance stretcher, even in the ambulance, and take the baseline vital signs, do the initial assessment, and form an impression about the patient, and know that this patient, where this patient is at, if I don't do ABC, and I allow this crew to go further with this patient, the patient might not make it. So if you do that initial triage, it gives you an impression of that patient and know whether that patient is stable enough to go to another facility. That is what the initial.
Dr. Dadzie, some doctors say to me, I misunderstand the way they work. So if when I criticize doctors for not or when I criticize the health facility for not accepting this patient, I reveal I don't understand what is really happening within the system, because they're saying the no bed syndrome is code for a much deeper problem. They say, for example, that if a patient dies on your hands, there's a lot of things that happen. Help me understand from a doctor's perspective where I could be going wrong in that view, because I didn't really get it. But a lot of doctors keep saying to me that, look, you need to tread cautiously in this your criticism of the health facility for saying no. So I just want to understand. I'm not sure if you agree with them, but just explain.
I totally get it, Bennett. It's that's why in my first statement I said it's indefensible, even if, right? So how do I put this easily? Ghanaian hospitals are not well equipped, and sometimes patients will die on you and you'll be helpless to help them. It's a horrible feeling. And over time, some medical professionals will flee the country to escape that feeling. Some will become callous. Some would leave the profession. So it's not a good place to be. Now, when you take on an emergency that you know you cannot help, you know as a doctor that we can't help this guy. Do you still want to take him and go through this very horrible process of watching somebody die? Right? That is one. Two, that whole thing of this patient is going to need a lot of care. And do we really want to commit a bed to this patient who probably cannot even pay? So I'm giving you sort of the background of this. Who cannot even pay? Do we really want to commit the bed to that? The third thing is resources. I mean, this is going to take a lot of resources. Do we want to commit to that? Another thing with the no bed thing is, oftentimes it's not even the doctors who tell the ambulance crew there's no bed. It could be an orderly, it could be a nurse. I mean, it's not structured at all, right? So all these things play a role. But if I could go back in 1986 and 87, two doctor groups in Cook County in Chicago wrote a paper. They wrote two papers, one in 87, one in 86. And they talked about the phenomenon of dumping. They saw a lot of private hospitals were dumping patients to Cook County, which is one of the bigger community county hospitals in the country. And so basically, if you went to a private hospital and they saw you a minority or you don't have insurance, they just told you, we couldn't take care of you, and go to Cook County. And the federal government got involved and passed the law called EMTALA. And EMTALA basically is, let me see if I can, Emergency Medical Treatment and Labor Act, right? So they passed EMTALA. And EMTALA basically means that if a patient walks into your hospital, even if the patient collapses in front of your hospital, you're supposed to do three things. You're supposed to screen this person because it's an emergency, stabilize them, and either admit them or send them to a facility that can take care of them. Failure to do this would cost the hospital anywhere from $50,000 to $129,000. The physician on call would get charged pretty much the same thing. And you'll be kicked off the Medicare. Medicare is the largest government insurance in the US, and it's a financial blow. You also get a visit from the Inspector General of the CMS, and Bernard, believe me, you don't want the Inspector General of the CMS in your hospital. It's not fun. And then come the civil suits from the family. So EMTALA has changed that massively, this behavior, and I think Ghana needs such a law. In the sub-region, Kenya has such a law, South Africa, even Nigeria, Mozambique, and Uganda all have these laws that ensure that if a patient walks into an ER, they get care. It's about human life, and irrespective of what kind of stress you are under, you have to give your best. I know I get Ghanaian doctors and where they come from and how frustrating it is sometimes to watch a patient die and not be able to do anything. But I don't think the general public can put themselves in their shoes. I wish they could. And so then it's incumbent upon the medical community to do its best. And that's only thing you can really do. So to probably summarize, I get where they are coming from, but you're dealing with human life, and human life matters. And we need a law that ensures that this is done. And I think it's easy to craft this. And then thirdly, if you are going to have this law, then the government should also make sure that physicians and nurses have the equipment and the stuff necessary to stabilize and take care of patients. And also hospitals have to make sure that not anybody at all can tell an ambulance crew that there are no beds. There's no reason an orderly should be able to tell the ambulance crew there's no bed. There's no reason a nurse should be able to do that. I mean, that's something the CEO of the hospital should know. Somebody high in administration should make that call, not an orderly.
We'll leave it here. Thank you, Nana Dadzie Ghansah, who's originally an anesthesiologist, but of course a clinician with a lot of experience in health care. I'll take a final comment from you. How encouraged or discouraged are your team after what happened on February 7 with all the controversy?
I think that we try to get them some kind of psychological help, because there's something called post-traumatic stress disorder. When people go through some of these situations and handle such cases, when they come back, we have a psychology team that we send them there to kind of help them to get over some of these emotional traumas that they go through. So that's the way we are trying to help them to get back on their feet, because seeing a life just slip out of your hands sometimes can be very traumatizing. So we just give them those psychological help to try to bring them back on their feet.
So a big thank you to our two guests who have brought to us some very important recommendations around the need for a central command center to manage emergencies, and also a law to make it impossible for hospitals to say no bed. We're speaking to Nana Dadzie Ghansah, who is a health professional with many years of experience, and also speaking to Martin Amua, who is from the ambulance service. When we come back, we switch to something completely different. I'll be speaking to the group CEO of Goldfields, Mike Fraser, on their 2025 results. He has some very interesting to say about Ghana as a mining destination and what the results mean for the future of Ghana's gold. Stay with us.